Hello everyone, and welcome to our webinar today. My name is Lee Barrett. I'm Executive Director of ENAC, and we've got an excellent panel that we have gone through and identified to really give you a very good overall understanding of managed service organizations. So also what I wanted to tell you is, before I introduce the actual name of the panel that we're going to be having, is to tell you that we'll be going through presentations. Each of the panelists will be going through their presentations, and then we'll have plenty of time for Q&A at the end. The name of the presentation and the webinar that we're going to be having is Understanding the Role of Management Service Organizations, or MSOs, in Achieving Meaningful Use and Mitigating the Risk of PHI Disclosure. We've got an excellent panel for you today to talk through a lot of the content pieces, and I will in a couple of minutes be going through some of the objectives as well as the challenges that we see with MSOs, and hopefully that will provide you with some context for the panel that will be giving you a variety of different perspectives addressing some of the specific challenges and objectives that we've got. So first of all, as Ron had indicated, what we'll be doing is we'll be going through the presentations and that each of the panelists have, and then we'll be having Q&A at the end. As Ron indicated, I'm Lee Barrett, Executive Director of ENAC. And let me introduce our panelists to you. So Craig Beam, who is Executive Director of MedChi Network Services, which he heads a firm that offers management services to physician practices. M&S is the largest state-designated MSO in Maryland and the co-recipient of the Regional Extension Center grant. M&S manages 2 accountable care organizations, and Craig is the Executive Director and serves on the management board of both. He's also leading an expansion of ACOs and related services to enhance the private practice of medicine. Prior to joining M&S, Craig worked as the healthcare business consultant for a small firm in the Baltimore region. He also worked at Erickson Living, a large-scale developer and operator of continuing care retirement communities. He served a number of roles for that company, with the most recent being Corporate Affairs Manager. He holds a BA from the University of Maryland, College Park, and an MBA from Loyola University Selinger School of Business. Next, we have Sharon Klein, who is a partner at Pepper Hamilton. Sharon has over 30 years of expertise in legal issues relating to healthcare information technology, medical banking, and regulatory work relating to healthcare privacy and security, as well as data management. She's a member of the California and Pennsylvania bars. In addition to practicing with private law firms, she was on the executive management team and associate general counsel of Shared Medical Systems Corp., which is now Siemens Medical Solutions Health Services Corporation. She's an active member of HIMSS. She's a commissioner of ENAC and writes and speaks frequently on issues such as licensing, privacy, security, confidentiality, telemedicine, outcomes, disease management, as well as managed care. She received her undergraduate from Syracuse University and her law degree from Temple University. She served as a law clerk to the Honorable J. William Ditter, Jr. of the U.S. District Court for the Eastern District of Pennsylvania. Next, we have Luigi LeBlanc, who is the Technical Director for Zane Network. He's also co-owner of the company. And basically it's a certified woman-owned small business and assists organizations and groups to adopt emerging technology tools. Since 2000, Luigi has guided the health IT projects for federal, state, local government agencies and for the private sector. And when they formed the ZaneNet Connect, the company's health IT subsidiary, it became a MSO, and he steered it to become ENAC accredited. He's trained health professionals on the use of telehealth technology for research and business improvement. He's participated as well in product development initiatives and provided international telemedicine consulting services. He's directed not only the development of their ZaneNet Connect to connect over 100 primary care providers in Maryland to implement certified electronic health records. He currently leads the implementation team responsible for building an island-wide EHR implementation of the British Virgin Islands, which was very interesting to me, which links a hospital, a clinic, a mobile MRI, and 3 pharmacies into a community exchange. He served as technology director of the Howard University Telehealth Sciences and Advanced Technology Center, and he set up a protocol model for its chronic disease health portal effort. He serves on the Maryland MSO Advisory Board, the Maryland Health Information Exchange Policy Board, and the Caribbean Policy Institute Board and the Caribbean American Political Action Committee. He's a bachelor's degree in electronic engineering from Hartford University and a master's degree in public health from Howard University of Medicine. His background in both engineering and public health provide him with a very interesting overall perspective, which we'll be looking forward to hearing. Bill O'Byrne, who is the executive director for the New Jersey High Tech, which is an organization was basically selected by the Office of the National Coordinator to be New Jersey State Regional Extension Center under ARA. High Tech is responsible for assisting New Jersey's medical providers in the transmission from paper records to meaningful use of electronic health information systems. Most recently, Bill was the state coordinator as well of New Jersey's Office for the Development, Implementation, and Deployment of Health Information Technology. He served as the New Jersey Project Manager for the Health Information Security and Privacy Collaboration, HISPIC, which was a group of 43 states and territories to identify and resolve barriers in interoperable HIE. He founded the New Jersey Adobe, HIPAA, and HINT Task Force, in addition to the smooth transition of the national provider identifiers in the new 5010 and ICD-10 HIPAA transaction code sets. He served as Adobe's Manager of Enforcement, directing regulatory enforcement, investigations, and proceedings against violators, which include stakeholders such as insurers, agents, brokers, public and adjuster violators. And he was also Adobe's liaison for all state and federal HIPAA, privacy, security, and application issues. He's a graduate of Seton Hall University and School of Law and began his career in 1970 as a captain in the U.S. Marine Corps, serving in Vietnam with the 1st Marine Division. So Bill's got a very interesting and very excellent background, and I've known him for many years, so we'll be looking forward to hearing his perspective as well. Sarah Orth, who is Chief of Health Information Technology for the Maryland Healthcare Commission Center for Information Technology, is also presenting here, and her responsibilities include analytical, operational, and program management of activities to advance health information technology initiatives for Maryland, specifically in the areas of EHR, state-designated MSOs, health information exchange, and telemedicine. Sarah holds an MA with a concentration in health policy analysis, and she previously worked for the Department of Health and Mental Hygiene in the Office of Health Policy and Planning. We have, and ENAC has an excellent partnership with MHCC, and Sarah has been a prime liaison for us to work with with that state and on a number of the initiatives that was mentioned as part of her bio. So with that, that's our panel, and we will go to the next slide, Ron, to talk about the agenda for today. So the agenda really is going to be, we're going to be starting off with Sharon Klein. Sharon's going to be providing a review of the regulatory compliance provisions and their impacts as it relates to really healthcare reform, MSOs, and she's got a wealth of experience and background here, which will provide some excellent context. Then Sarah Orth is going to be talking about the Maryland MSO model and what they've been doing in Maryland and the legislation that they've created and the advisory group that they've put together and how they've they've gone forward in developing their overall program. Bill O'Byrne is going to be talking from kind of the Regional Extension Center and that of what they're doing not only in New Jersey, but also providing kind of an overall context from Bill's perspective from the REC, healthcare reform, how this all fits with the HIEs, and really the National Worldwide Health Information Network, and some of the perspectives that he has, especially around security and privacy. Craig is going to be talking about his perspective as far as, again, the MSO model and what they're doing as far as his organization and his perspective on the industry. And Luigi will be talking about what Zane Networks is doing and their perspective as well, not only in relation to MSO modeling, but also that of accreditation and the need for security, privacy, confidentiality, and some of the impacts and issues that they're seeing there. So that provides you, hopefully, with a very good perspective, background on really what we're going to try to cover this afternoon in our hour and a half with you. And as I indicated earlier, we'll have plenty of time at the end of the session for Q&A. So please, even when we finish, please stay on the line and listen into the Q&A. We'll also be, we're recording this, so we'll have both the slides as well as the audio available, certainly on the ENAC website and perhaps others as well from the panel. Will have it on their websites as well in the event that you know of somebody that wasn't able to participate in the webinar. Let me turn now to our objectives and what we're going to look to go through. You know, as I've kind of laid out the panel and the various subject matter and topical areas that they're going to address, we're going to try to focus on certainly the role of MSOs in the implementation of EHRs, achieving meaningful use compliance, the need for risk mitigation. And really, we think that the area of privacy, security, confidentiality, as you're dealing with PHI, as we're dealing with really all of this clinical information that as well is starting to flow between various stakeholders and various exchanges, that the risk is continuing to increase for breach. And so we want to talk about some of that, and we also want to talk about the Office of Civil Rights. Many of you may be aware that the Office of Civil Rights has taken on an even more increased efforts this year around enforcement of HIPAA. And so they originally had gone out and indicated that they were only going to audit about 25 organizations. They have revised that. They revised that at the beginning of the year to audit 150 organizations. So we're seeing that OCR is taking a very proactive role here on the enforcement side of the equation. We're also going to be talking, as I mentioned, about the healthcare reform legislative regs. We'll also be talking about regional and national objectives of healthcare reform and how it fits with the national, basically, and the nationwide health information network vision. We'll talk to you about kind of the various MSO models and the fact that not all MSOs are created equal, especially as you talk about it and we address compliance issues. And lastly, we'll look to help you as part of your planning as you work with MSOs, or if you are part of an MSO, to define your organization's risk tolerance and to develop some strategies for addressing some of that risk mitigation. Next slide, Ron. The challenges that we've got really are in understanding, I think for the entire industry, understanding the roles of MSOs, how they're playing as a stakeholder, their impact in the nationwide health information network, their impact, how they're impacted in relation to healthcare reform, and the issues around risk mitigation, privacy and security issues. And again, I think these are all challenges that not only MSOs face, but a number of the stakeholders within healthcare reform as we're looking to achieve that overall vision, whether it's an HIE, an ACO, an MSO, meaningful use, providers, the payers, all the labs, all the various stakeholders that are going to be making up the kind of the exchange of clinical data, as well as we start getting into a lot of the analytics and building towards this nationwide health information network. So, next slide. So what I'm going to do now is I will turn this over to Sharon Klein, who's going to be taking you through some of the regulatory compliance provisions and impacts. Sharon.
Thank you, Lee. What I will do in a few minutes is go through the regulations as background for the discussion, and then the impact on MSOs and what MSOs should be really thinking about in terms of compliance with those regulations. So this all started in 1996 with HIPAA, and HIPAA really had three different tranches. One was EDI transactions, claims remittances, privacy and security rules for covered entities such as payers, providers, and clearinghouses, and then business associate compliance that was through a business associate agreement. Ron, next slide, please. Under HITECH in 2009, as part of ORA, $20 billion was allocated by the government to increase EHR adoption. And the provisions of HITECH included much greater accountability for business associates. Many of the HITECH provisions were modified, and indeed there are many provisions added for data breach, which did not exist under HIPAA but did under HITECH. So MSOs need to be knowledgeable about HITECH, not only to assess whether their current and future services comply with HIPAA HITECH, but also to build internal policies and practices and procedures to help with compliance. Next slide, please. To put a finer point on it, under HIPAA privacy and security rules, you need to protect the disclosure of protected health information, which is information about medical health of individuals that's identifiable back to a person. A business associate is an organization that performs activities on behalf of a covered entity. That covered entity, again, would be a payer, a provider, or a clearinghouse. And indeed, MSOs squarely fit within the definition of business associates, and HIPAA regs provide that services to or for a covered entity where it involves disclosure of individually identifiable health information will be protected. Next slide, please. So for managed services organizations, they really need to first take a hard look and determine compliance status under HIPAA HITECH as a business associate or a covered entity. And in either direction, they have to develop policies and procedures to ensure compliance with all the federal and state regulatory provisions to protect health information. Under HITECH, really a business associate is held to most of the covered entity requirements, including reporting information security breaches and being subject to civil and criminal penalties. Before, under HIPAA, you had to have a business associate agreement and only worry about complying with the terms of that agreement. Now, under HITECH, those business associates and MSOs take on that regulatory liability directly. And indeed, if you look at, as Lee indicated, OCR has been very, very active, and it's done the 150 audits and has what they call a wall of shame for entities that have exposed greater than 500 records of PHI. And if you look at that list on the OCR website, you'll see a lot of MSOs. You'll see a lot of business associates, such as Aramark and Towers Watson, and on the EHR side, Siemens and McKesson. There's an MSO of Puerto Rico, Inc., and Millennium Medical Management Resources, Inc., all MSOs. So clearly, MSOs and business associates are guided by HIPAA HITECH, and if they do not meet the compliance obligations, they're also subject to the same scrutiny and fines and penalties of a business associate and covered entity under the regulations. Next slide, please. So from a legal perspective, data privacy should be front and center for all MSOs. Since without it, an MSO can be liable for fines and penalties, monetary loss, lawsuits, and brand damage to their entities and businesses. Just a word on monetary loss. The situation every second of every day is getting more dire in terms of cyber theft and breach scenarios. Probably a year ago now, they indicated that there were 72 cyber attacks per week for a median cost of $5.9 million per year. And those have been escalating at about 20% per year. So the likelihood that you're going to be in a breach scenario is very, 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 very likely. And what we need to do is really think through how to mitigate that before it happens and to have privacy by design built into your organization to assure compliance under HIPAA high-tech. Next slide, please. So just a quick review of penalties and enforcement, since high-tech actually upped the ante in terms of compliance breaches. So both civil and criminal penalties under high-tech increased. The civil monetary penalties increased by having 4 tiers of civil penalties from $50,000 per violation to $1.5 million annually, and criminal penalties with fines up to $250,000 with 10-year imprisonment, and also enforcement under OCR. The additional tiers under high-tech involve something called willful neglect, which is a new concept that was introduced by high-tech to capture individuals and entities that knew what they should be doing to comply with the regulations, but failed to do so. So they took a blind eye, if you will, to compliance efforts, and you'll see in the fines and penalties that OCR has, from an enforcement perspective, as well as the FTC, been very harsh on those entities. In addition to federal compliance, state attorney generals have authority to bring civil actions on behalf of the residents of states as well. Next slide, please. So to look at some recent fines and monetary loss, Signet Health, which actually wasn't a breach violation, it was a HIPAA violation for denial of patient access to medical records and for failure to cooperate with the OCR investigations and audits that Lee referenced earlier. And they got hit with the highest fines for that lack of cooperation and willful neglect of $4.3 million. Similarly, Massachusetts Eye and Ear Infirmary, for lack of adoption of implementation of policies and procedures, which led to the theft of a laptop with over 3,000 patient records exposed. They got $1.5 million fine. And CVS, as well as Rite Aid and some other third parties, received a $2.25 million fine by FTC. So you have several agencies administering this, OCR and FTC, on the consumer side, for noncompliance with their privacy policy in not disposing properly of labels containing PHI. They were actually left out in some open trash barrels. So that's a sampling of agency enforcement. Next slide. But the real risk and threats that we're seeing build and build and build like a cascading drum roll are private actions, especially class actions, in data breaches and litigation. So the first couple just give you a flavor for the market. Obviously, you've all heard about the LinkedIn exposure on unencrypted password data, and then Facebook, which seemed to be very happy with this $9.5 million settlement when it had a beacon program that broadcast and blasted what the consumer Facebook person was buying or renting on Blockbuster and buying on Overstock.com. Fair Credit Reporting Act class actions for Zappos was filed one day, 24 hours after the breach was reported of 24 million customer records. In the healthcare side, there's a class action pending here in California for $1,000 per violation with 600 individuals' data that was accessed. No likelihood of harm because actually the folks that accessed it were plaintiff's attorneys, but that incident of security breach was enough under California law to be able to file the class action. And most recently, the 11th Circuit upheld the certification of a class for data breach on a theft of a laptop with 1.2 million members in Curry versus Avmed. It was a payer. And Sutter Health has 12 lawsuits that have been consolidated pending class action on a theft of a laptop of 4.24 million patients with potential damages that could exceed 4.25 billion with a B million dollars. So next slide, please. Brand damage in terms of your reputation as a business also flows from lack of compliance from HIPAA high-tech regulations for MSOs and business associates. Under Choice Point, that market cap of that public entity dropped $720 million after the breach was announced. And this is not including the damages that they incurred in the actual monetary loss and fines and penalties. This is just brand damage. And the time to recover your brand could be almost a year with a diminished brand value of about 20% based on those data breaches and losses. So the takeaway from the regulatory and legal analysis for MSOs and the importance is that all MSOs really need to dig deep and understand how their services impact PHI and their obligations as business associates and institute policies and procedures compliant with HIPAA and high-tech in a fashion called privacy by design. So it starts at the lowest level with awareness and goes up to the top with the executives and policies and procedures to mitigate against those data breaches, which will happen, and be able to avoid the fines, penalties, lawsuits, and brand damage, which will flow from those data breaches. So, Lee, that's the introduction and background on the legal and regulatory side.
Thank you, Sharon. That was excellent. And I'll tell you, I will tell you that from what I'm seeing, I'm not sure about any of you that are on the call, but on a daily basis, I subscribe to a number of these news services, and I'm just seeing on a daily basis more and more of these breaches that are occurring at different organizations. And as Sharon was sharing with us, the brand value or the public relations impact, never mind the penalties, is extremely large, as well as obviously the wall of shame that you mentioned with OCR, but a lot more controls and certainly far more oversight that's taking place in the industry on it. Okay, so let me, next we're going to go into and have Sarah take us into the model that MHCC has implemented in the state of Maryland regarding MSOs. Sarah?
Thank you, Lee. Today I will provide a high-level background information about how we started the MSO program in Maryland and the progress that MSOs have made to date and how we see the program moving in the future. Next slide, please. So widespread adoption of electronic health records has the potential to save the healthcare industry about $81 billion annually. And this is mostly gained through creating efficiencies and eliminating duplicative tests. So in 2009, Governor Martin O'Malley signed into law a law that enables the MHCC to designate management service organizations. And this state designation requires MSOs to achieve ENAC accreditation. Next slide, please. Next slide. Okay. So the Maryland Healthcare Commission has 5 centers, and the Center for Health Information Technology is the regulatory agency responsible for expanding health IT adoption in the state. And one of the ways by which we do that is designating management service organizations. Next slide. So management service organizations came up as a way to address the challenges associated with provider adoption of electronic health record systems. And the challenges related to EHR adoption that MSOs can address are the process of selecting an EHR from over 1,700 certified vendors, the cost and maintenance of the technology, and ensuring privacy and security. So this ties back to Sharon's presentation. MSOs can assume the responsibility of managing the privacy and security of the health information and they offer hosted EHR solutions as an alternative to the traditional client-server EHR model, whereby practices maintain the hardware and software in their facility. MSOs maintain data within a network operating center or secure locations. So MSOs promote the adoption of health IT beyond just electronic health record use, and they offer centralized administrative and technology services via the internet as well. In Maryland, we see generally 3 types of business models of management service organizations, which include hospitals and health systems, small technology businesses and consulting firms, and EHR vendors. Next slide. So MSO state designation is an MSO that has met ENAC accreditation and has complied with the industry best practices. Currently, there are over 95 criteria and that an MSO must meet and show that they have met. The MSO must apply to the MHCC and meet initial requirements to receive candidacy status, and then has 1 year to go through the ENAC accreditation process and become officially state designated. Next slide. So why state designation? An emerging industry requires standards that will instill confidence in stakeholders. That MSO state designation symbol across Maryland now signals to providers that these organizations have been vetted by the MHCC and have met accreditation by ENAC. An ENAC accreditation ensures a high standard of quality in handling PHI, compliance with state and federal laws and regulations, and encourages quality improvements in products, services, and workflows. Since the accreditation and state designation must be reconducted every 2 years, this is an ongoing process. It's not just a one-time thing. Next slide. So MSOs are really the central part of a huge network. In Maryland, the MSOs touch Health Information Exchange. They're also part of the Regional Extension Center. There's an MSO advisory panel, which we'll talk about in a little bit. They work with different EHR vendors and physician practices and telemedicine. So you can see they're really touching all components of health IT. Next slide. So in 2009, the MHCC convened an advisory panel to make recommendations of the criteria for what should be considered for MSO state designation. Approximately 40 stakeholders participated in that original panel and developed recommendations for criteria related to privacy and security, technical performance, business practices, resources, security and operations, and services. Next slide. Since 2009, the panel has met almost annually and reviewed and updated the criteria for state designation. In 2011, after about a year of operating the MSO program, MSOs suggested that we add a services component to the criteria, which you may have seen in the ENAC criteria recently. We've also, the MSO advisory panel designed an MSO provider satisfaction survey that we administer to their clients to see how is the program doing, what are the key elements that make an MSO successful. In 2012, the panel identified required criteria. And so as we look to the future, we're going to see how can MSOs be a conduit to connecting ambulatory practices to health information exchanges, and how can they help practices implement telemedicine. So at 2 years, the program has about 22 MSOs in total that have been awarded candidacy status, and 14 of those have completed their state designation. There are about 7 MSOs currently that are the hospitals and health systems, 6 that are small technology businesses and consulting firms, and 1 EHR vendor. Next slide. So in summary, we've achieved the legislative requirements 17 months in advance by creating and initiating the MSO state designation program in 2010. We created this industry in Maryland and established standards that MSOs should follow. We've implemented a sustainable business model for the Regional Extension Center. Currently, the MSOs, in partnership with the Regional Extension Center, have signed up about 1,745 priority care providers that have committed to wanting an EHR. We've shaped job creation and generated business opportunities in Maryland through the small businesses of the MSOs, and we've established a model for other states to consider. We've had lots of learning lessons and had tweaks along the way to the program that other states could replicate. Next slide. So how do we enhance the value of MSOs in the state and create a program that is sustainable for the MSOs? Maryland considered this and developed a state-regulated payer EHR adoption incentive program, which was made to kind of mirror the federal EHR adoption incentive program. And so a component of the state EHR adoption incentive program is if a practice uses a state-designated MSO or an MSO in candidacy status, they are eligible for an additional financial incentive. Next slide. So in summary, Health IT is considered to be the underpinning of healthcare reform, and achieving the benefits requires advanced use of the technology. Providers are struggling to use the technology. We often hear that they're clinicians and don't necessarily have the time and the resources to implement and use technology in a way that can impact care outcomes. MSOs are a way to fill that void and can provide services to these practices.
Thank you, Sarah. Appreciate it. That was an excellent overview of what MHCC is doing in Maryland, and hopefully that provides many of you with a great perspective on that model. So let's turn to Bill O'Byrne, who's going to be talking about Bill's experience as Executive Director of the Regional Extension Center, NJ High Tech, in New Jersey, and his perspective not only from New Jersey, but also that of the broader scope. Bill?
Yeah, thanks very much, Lee. It's a pleasure to speak with you and with my colleagues on ENAC, as well as the people who are attending this conference. The only point that I want to make is that sometimes we're trying to figure out, well, why is there such a need for privacy and security? And, you know, it seems obvious, but the essential part of privacy and security is the stability of people's reaction to the sharing of clinical health information. If there is no integrity to the process, then it all falls apart, and all this money and time and effort we're putting into health information technology will certainly crumble. So it's important for obvious reasons, but if you could go to the next slide, it's also important because some states have taken a kind of a leadership position and require that organizations become accredited. In the case of Maryland, as we've said before, there is a statute created by their legislature which mandates that certain entities be required to be accredited by ENAC, and certainly that's an obligation that can't be avoided. In New Jersey, there's a statute that was passed in 2007, the New Jersey Health Information Technology Act, and that requires that custodians of electronic PHI, such as clearinghouses, third-party billers, third-party administrators, payers who use clearinghouses, and those who send and receive claims, have to be accredited by a national standard-setting organization. It should be noted that the word custodian is broad in nature, so it's not limited to the organizations that I described. And if we had MSOs operating in New Jersey, I would certainly expect that they would have to be accredited as well. As a result, there are at least 2 states where MSOs have to be accredited, but my perspective is a little bit different. As a regional extension center director and previously with state government, my thought is that privacy and security not only will subject us and everyone else to violations of federal and state privacy and security laws and the penalties that adhere thereto, but also there is a professional irresponsibility and lack of shareholder and stockholder concerns should costly remediation plans be required because of some audits. That kind of irresponsibility is pretty unexcusable in my regard, because it's so easy to identify where the risks are and to take the proper steps to make remediation of wherever the risks are found. That's not to say that privacy and security is easy by any means, but the task here is to make an effort. And one of the primary ways to demonstrate that you have made an effort in regard to privacy and security is to have this kind of accreditation process undertaken in your organization. I recall quite vividly that on several occasions when I was in the state, there were insurance companies that had releases inadvertently of protected health information, and the cost of undertaking remediation was absolutely absurd, and it was just so much money, time, and effort that had to be put into the notifications and remediation that it was just not worth the effort. So I think the idea is that if you want to have peace of mind, if you want to have good business practices, regardless of what you call yourself, if you are collecting, holding, aggregating, auditing, sending, transmitting protected health information, the watchword is privacy and security, because there's really going to be no excuse if you violate those rules, and the cost is too high, and therefore, in my estimation, the price of taking the extra step to have it accredited is well worthwhile in terms of good practice and peace of mind. So that's my strong recommendation. I know that's what's required in New Jersey, and probably should be required in other places as well. Thanks, Lee.
Thank you, Bill. Appreciate it.
Yeah.
Great perspective, and I think it's a very important message that Bill has been making here on the emphasis, and you're seeing a real theme here around privacy, security, confidentiality, and the concern and the risks that are there. So thank you, Bill. So next we're going to have Craig Beam, who's going to talk to us about what their organization is doing and what Craig is involved with, not only within the ACOs and the MSOs, but I think he'll provide some good perspective on the model that he's been involved as well. So Craig, let me turn it over to you.
Great. Well, thank you, everybody. Thank you for having me. So I'm probably going to take this down to a little more personal level, a little bit of background on MedChi, and then we'll go into MedChi Network Services, the MSO specifically. But we are the Maryland State Medical Society, founded in 1799. It's one of the oldest and largest in the country, with 7,500 members. Overall, the organization was, of course, and has been supportive of health information technology and initiatives that help enhance care for patients and services, of course, from physicians. So this was certainly an arena we wanted to be involved in. I'd say until Sarah and the MHCC brought forward the MSO program, it was a somewhat ambiguous arena to try and start in unless you were a reseller or another technology organization of some kind. But through the NHCC and ENAC, we decided to kind of jump in the pool, throw our hat in the ring, and we became an MSO. Next slide, please. So our model is probably a little bit unique in that we are not, or at least we had not been, a technology company. MedChi, as a nonprofit physician association, has been very good at continuing medical education programs, legal advocacy support, physician communications, practice management, all of the tertiary components of an MSO as I view it, and of, I think, what technology firms should be offering, but in kind of a unique way. And so what we really did was to layer on subject matter experts in IT, networking, infrastructure, technology consulting, and of course privacy and security, which I agree with the other panelists is the heart of the program. So next slide. I would say one thing I want to speak to is, of course, there's a dramatic reason to do this and to protect people. But from my perspective, a lot of it has also been a marketing component. Something that I personally feel is lacking in this industry, or at least in the health IT industry so far, is good, credible sources of information that aren't otherwise related to other entities. So that's not to say that an EHR vendor, for example, can't be a very good provider of information. But from working with physicians for a very long time, I see that if someone enters a physician office as a reseller or advertising a product, they get a very different reaction as opposed to a credible source of information. And so I like to think that MedChi has been a trusted source, but I would say that accreditation from groups such as ENAC is just one more way to build credibility and build evidence of the fact that you are able to bring good information to a wide variety of end users, both patients and physicians. So our perspective has really been, and I think this is probably one of the great things of the Maryland program, is that all the MSOs can work with physicians to find solutions to help reach meaningful use, to get incentives, to participate in some of these exciting new initiatives without necessarily selling a product. So I found to be an exciting thing to be involved in. And ENAC, of course, then becomes that foundation that allows you to enter the practice under that mentality rather than as just a resale. So next slide. So probably the theme is this opens the door to a lot of other things. Physicians, and especially small practices, will continue to need credible sources of information to help run their businesses. And as items such as PQRI, e-prescribing, ICD-10, that happens in the somewhat near future, and of course meaningful use stage 2, all of these things need credible groups to speak out and help physicians. And I think that we're positioning ourselves through ENAC and through partnerships with the Maryland Healthcare Commission, the Maryland Regional Extension Center, other MSOs even. We're positioning ourselves to offer those services in a very appropriate and I think positive way for physicians. And then probably the thing that I'm most personally excited about is, you heard Lee mention the ACOs. Through Medicare Shared Savings Programs, commercial savings programs, hopefully, Maryland has a lot of exciting policy around the health insurance exchange and health enterprise zones. There are a lot of interesting ways that good neighbors and community participants can help shape the industry so that it has very positive outcomes for physicians and for patients and for the industry professionals. And I really applaud programs, national accreditation programs like ENAC and the MSO program, because it gives people a good, confident source and base to work with. That's been our experience so far, and I think that it's a very positive one and a very exciting one for the future. So thank you all very much.
Thanks, Craig. That was excellent. Great overview on what you're doing at MedChi, and as well as all the various initiatives that you're involved with, as well as kind of your perspective on the future for MSOs. Thank you. So next we're going to go to Luigi LeBlanc from Zane Networks to talk about their perspective in relation to what they've been doing in MSOs, and he's got a great overall perspective as well on the industry. So I'll be interested to hear Luigi's perspective and recommendations as well. Luigi.
Thank you, Lee, and good afternoon, everyone. I'll be talking a little bit about Zane Networks, introducing the company, and how we address the marketplace. And I'll also talk about our current services and some recommendations based upon where ZaneNet sees the market going. Keep it in line with the privacy and security implications of the market. So Zane Networks is a woman-owned small business, federally certified as well as state certified, and we became an MSO in May of 2011. What we bring a skill set of individuals who are health IT professionals, who are project managers with a specific focus in physician adoption to EHRs. In fact, some of our individuals have actually graduated. We've recruited individuals from the workforce development initiatives that have occurred, so our people come with a skill set already in certified skill set. And then we also have IT specialists that help provide our technical side of the services. We currently have about 154 providers in our network, and we're growing every day. Next slide, please. Just to look at who our providers are, we've got 150 providers spread out throughout the state. We're focused a lot in the central and southern part of the state, but you can see from our numbers there that we've got a fair mix of Medicare and Medicaid providers. We've got 150. All our providers have signed up for grant credits. With regards to the Regional Extension Center program, 91 of them have achieved Go Live credits, and we're working diligently to get to the M3, meaning for use at the station, actually the M3 Regional Extension Center component of it. And about, now it's about 100,000 or more, our providers have received about 100,000 in their incentive payments. Next slide, please. So our implementation managers that are out there in the field, as Greg mentioned, have become trusted sources to the providers that we serve. And so when we go in there, we provide them on-site implementation, training, and support. We also provide them practice workflow redesign services. We're talking to them about some of the incentive and the programs that are out there that they can benefit from, and encourage them to take the adoption process seriously, ensure that their team is being trained. We're always keeping an eye on and keeping them aware of the privacy and security efforts that are out there, and we're able to do that because we're sure that our individuals, we focus all the time on the implications of privacy and security so that we can best address our marketplace. We're an unbiased source so that we work with the providers where they're at, with the systems that they're at, and help them implement that successfully. Next slide, please. So our current services certainly are along the lines of the stage 1, meaning for use services, so we're helping our providers to get there. Other incentive programs that are out there in terms of, in Maryland specifically, we're helping them qualify for those. We also provide IT managed services to our providers. And the reason we do that is we recognize that when we're working with these providers, a lot of them just don't have the internal resources to manage systems, so we certainly move them. If they've got a client server-based system, we advise them and guide them to moving that either to our secure data center that's been certified in the state, or we make sure that they go through a HIPAA risk assessment and analysis so that their system is protected and their practices are also have also been vetted. And then we're starting to see movement from our providers in terms of the managed services because they're starting to realize, and as they're reading about the OCR audits that are growing, they're starting to realize that they may not want that risk, or they may want to ensure that they've got a trusted source, a reliable source that's helping them to mitigate the risk. And again, we do have a certified data center that we use when we move providers, if they're not using a SaaS-based EHR from the vendor, we recommend to them to move into a co-located facility that meets the criteria, and we're starting to see some movement in that side of it in the marketplace. The services that we see that are coming and we're positioning for are certainly to move our providers, those who are ready, who have attested to stage 1. We're beginning to move them towards connectivity and benefiting from leveraging the state's health information exchange and the tools and the benefits that provides. Particularly small providers who have not been able because they just don't have the patient numbers to receive their labs through the exchange, directly through their vendors, the interfaces have been done. So now we're starting to see that providers can get that done, and in fact we're helping to advocate for that through the state's exchange. We're keeping a close look on the care coordination marketplace as these ACOs begin to form, and how these tools get applied by physicians who are now being asked to be responsive holistically for their patient panels. And we're looking at these tools who are more and more being delivered as a software service tool, and how we can help providers address that within their workflow, and certainly keeping an eye on privacy and security. Telehealth and telemedicine, recently in the state of Maryland, the law has been passed allowing providers to receive reimbursement for telehealth and telemedicine. That's very exciting for us, and we're positioning to provide that service to our members. And certainly other tools such as Direct, how that plays a role within telehealth and telemedicine, and how the consumer engages within these ACO models is another target focus area for us. Next slide, please. So we look at it from the 3 C's. We believe that this market is moving towards more communication, collaboration, coordination. And there's going to be tools that providers are going to need to be able to help them more effectively manage and increase revenue as well as efficiency. And so what we're doing at ZaneNet is helping to understand these tools, deliver these tools to the provider, to our marketplace in a way that is cost effective, that adds value, but it is also delivered with the assurances, the trust that it's going to be, it's going to help mitigate risk in terms of breach of PHI. Next slide, please. So we started an effort, and our goal is to get 50 providers by the end of the year connected through our Community Provider Connect gateway. So it's a hub that's going to connect to CRISP, our State's Health Information Exchange, so that we can get our providers results delivery in terms of lab and radiology, but also begin the process of helping them to comply in terms of their public health immunization reporting purposes. So we're going to be working with the last mile, working with the vendors. In particular, we're starting with NextGen, Clinical Works, and some of the smaller vendors like DigiDMS, MIA, and Savacity. And we're starting to see that these vendors are seeing value in MSOs, helping them to bridge that connectivity to the state's exchange. And fortunately for us in Maryland, the state's exchange has been a very good partner to MSOs and sees the value of MSOs, whether they're hospital-based or they're ambulatory, non-hospital-based providers. They see that as a value in helping to increase adoption. Next slide, please. And so, again, with telehealth, we see that as a real business case because the providers now have the incentive and the revenue model, and they can leverage these tools to be able to bridge, whether it's conventionally between the primary care providers and the specialists, or provide the consumer for disease monitoring services. We see that as really an emerging marketplace, and we're beginning to see trends, and providers are asking us about telehealth and the role that it can play. And where we see the MSOs playing a role is that we can now help within the workflow and also bring the tools together, whether those are direct messaging tools where the consult notes can be sent to that consulting provider, or whether it's querying the exchange at the time of a telehealth exam, and then bringing in the conventional video conferencing if they're doing a live exam of the patient. Those two coming together presents a real opportunity for MSOs, but of course with that opportunity we've got to keep a focused eye on risk and making sure we're ensuring privacy and security, because the entities, such the remote monitoring entities, the telehealth entities, are delivering more and more of that capability as a service. Next slide, please. So, as a small business, small woman-owned business, we just can't do this alone. So we fundamentally believe that in business we're going to grow together. So we're doing it in partnership, whether that's partnership with the state's medical society that brings the credibility, or whether that's partnership with the State's Health Information Exchange, guidance from the Maryland Healthcare Commission, our regulators, vendors. So we have to do it in partnership so that we bring the best of breeds to the marketplace that's going to really help the providers drive value and help them improve revenue. And at the end of the day, if we can't figure out a way to deliver this with an eye on increasing revenue, then we're just not going to get there. Next slide, please. So in summary, we're leveraging the success of the REC effort in getting adoption moving in Maryland particularly, and now we're beginning to formalize our strategy to aggressively pursue the specialists, dentists, public health agencies who now are beginning to look at how they may do this. We're advocates for interoperability. We believe at the end of the day that the providers are going to benefit if they can holistically get access to the data, if they can exchange securely the data and reliably. We promote the 3 C's, our communication, coordination, collaboration effort. We see telehealth and remote monitoring as tools that helps to promote those 3 C's. And we're focused very much, whether it's our privacy and security toolkit that we give to our providers when they sign up for our managed services. We make sure that everyone on the team always has a discussion with the providers around the issue of risk, around the issue of mitigating that, so ultimately they make the right decision. And they demand that of us. Thank you.
Thank you, Luigi. That was an excellent perspective on what Zane is doing, your model, and what you're seeing in the industry as well. So between you and Craig, I think you provided some very good perspective on your particular models and what you're doing, and then with Sarah talking as well about the Maryland-specific model and how that's working with MHCC. Very good overall kind of plan for Maryland. So what this slide is actually depicting, we're really at the cusp of a lot of changes that are going on with healthcare reform, and certainly get ready for a very exciting ride as this continues to unfold and healthcare reform continues to evolve. And with that, why don't we open it up for questions at this point. So while all of you are, and I believe that you can type in your questions, and we will ask Ron Moser, who is helping me in facilitating this webinar. He will be taking those questions and providing them to me, and then I'll be directing them to the various panel, either the entire panel or various panelists to answer. So in the meantime, while we're waiting for you to type in any of your questions, and I know all of you have a number of questions, let me start this off by asking a couple of questions to get people thinking. So Sharon, I've got one question for you. You gave the overview that you provided on really kind of the issues around the enforcement, some of the risks, especially as you start to look at this from the wall of shame from OCR, some of the implications regarding the public relations implications. What are you finding is the average PHI breach costing a particular entity these days? Is there any metric or kind of range on what that cost is?
Yes, the Ponemon Institute does a survey and then publishes a study about the average cost of a data breach. And in 2010, I think it was $268 per record that was breached, and it has been increasing year to year over 20%. So, I'm sure it's bumping up against $300 right now. But that dollar amount doesn't really add in the brand damage and the fines and penalties that we discussed earlier. That's just the amount to be able to do the forensic analysis, to understand who you have to send notice to, and to provide the notice, and also the remediation efforts so that the breach and the security incident would not reoccur. So again, it's bumping up against about $300 per breached record, and is set to increase beyond that at about a 20% clip each year.
Thank you. And let me just again ask anybody who has questions, please type them in, and we'll be glad to be going to those in a second. Just to add to what you were saying, Sharon, I had a particular story that I saw about a couple of years ago, and that talking about kind of the magnitude of a breach. And this was actually a payer that had a shredding company that normally came to the organization. They usually provided the shredding services on site, but in this particular instance, the mobile shredding unit was malfunctioning, and so what they needed to do was to take and load the claims that they were shredding and take those back to their main facility for shredding. And the next picture is on a newscast with a reporter reading one of the claims due to the fact that on the highway that the doors of the shredding unit blew open and all of those claims were all over the highway. The PR implications were of a unbelievable magnitude. So I mean, it's just that's just an example, but I am continuing to see, as I was indicating earlier, more and more of these news briefs and news publications that I subscribe to. Is on a daily basis, I'm just seeing more and more breaches that are occurring that are becoming far more public. So I think the implications are very significant.
Lee, if I could just dovetail on your example, the regulators are focusing on destruction of PHI in its end state. So we all need to make sure that we not only think about PHI in terms of obtaining it in a database, storing it, transmitting it, but if it is no longer needed, we need to make sure that we properly dispose of it. I mean, obviously, one example of that is the $225 million fine that CVS had, and Rite Aid had a similar one. But there is actually a really good FAQ on the OCR HHS website about the proper destruction of PHI that I would recommend, because that is definitely one of the focus points of the 150 audits that you mentioned earlier, Lee.
That would be terrific. That's great. Thanks, Sharon. Sarah, question for you while we're waiting for other questions from our participants. Based upon your presentation and what you've seen as far as MHCC, what are some of the learning lessons that you can share with some of the other states that in fact may be listening into the webinar as they are considering implementing an MSO model in those states?
Hi, Lee. That's a great question. Thank you for asking it. One of the key elements we found that have made this program a success is being able to work with the industry to develop the program requirements and to maintain the program. Without the assistance of the industry, ranging all the way from providers themselves to the technology vendors, health systems, and the MSOs themselves, we would not have been able to achieve the successes of the program that we have. Everybody brings a unique perspective to the program, and everybody that touches it seems to make it a little bit better. So we're always aiming to keep up with the technology changes as they come quickly and make sure that our policies and procedures for the program accurately meet the needs for physician practices. And we don't want to be having MSOs doing something just to be doing something. We want them to be adding value to care delivery.
That's great. Thank you, Sarah. I think that's a very good perspective, and hopefully one of the objectives that we did have for this webinar as well is not only talking about some of the experiences that our panelists have had both in their organizations, but as they're looking at the perspective of the industry, but also what we're trying to do is, as you've heard from Sarah, what MHCC has done, what New Jersey has done. We have several other states that are taking on and have adopted other portions of legislation as far as accreditation is concerned. One of the things we are hoping that for other states is to gain at least an understanding of what Maryland is doing and that there is in fact a very good model that can be leveraged, and hopefully for those states that are listening, perhaps to take a look at that legislative model. And I know that Maryland, Sarah, as well as David Sharp of the Maryland Healthcare Commission would be more than happy to answer any other questions that you might have based upon their experiences.
Hey, Lee, that's very similar to a question that came in from one of the attendees.
Great.
Someone asked if the panelists, or if you believe that there will be other states requiring ENAC accreditation soon in addition to Maryland and New Jersey.
So I'll take a shot at that, and then if anybody else on the panel has a perspective, please chime in. So we are in discussions with a number of states, and we have a lot of inquiries and providing a lot of information. There's legislation in the states of both Maryland and New Jersey now having to do with healthcare network accreditation. It's called our Healthcare Network Accreditation Program, which is really for those states, any payer who in fact uses a clearinghouse or electronic healthcare network must have an ENAC national accreditation. So that's for those two states as far as our Healthcare Network Accreditation Program. Maryland also has legislation, I believe, Sarah, you can correct me if I'm wrong, having to do with e-prescribing networks as well as the Managed Service Organization, or MSOs, as we talked about. And we have a couple, and they're also looking at similar having to do with health information exchanges, which we have legislation on the books in Utah as well as Minnesota. So we're continuing to talk to a number of states who are looking at model legislation in both, obviously, Maryland, as well as New Jersey, Utah, and Minnesota. And if anyone who's out there, again, from other states are interested in having further conversation, we'd be more than happy to get into any more additional specifics. Sarah, I think you have mentioned, you and David, that some other states, in fact, have contacted you having to do with your model, and I didn't know if you have anything else to add.
Sure, thanks, Lee. Yes, we've talked to several states, maybe about 5 to 6, about the Maryland model, and it seems that most are interested primarily in the model with the regional extension center. So allowing and enabling MSOs that are state designated to be subcontractors of the regional extension center seems to be the primary focus of interest. And the Federal Office of the National Coordinator for Health Information Technology also views this as a sustainable model for the regional extension center. So as the REC funding is starting to wind down in the next couple of years and states are looking to plan their sustainability models for those organizations, I'd encourage you to take a look at the MSO model.
Perfect. Thanks, Sarah. Appreciate your perspective. Yes, Ron?
No, it's Luigi.
Oh, Luigi, yes.
I just wanted to commend the MHCC because I think from the regulatory side, the role they play in facilitating stakeholder meetings and bringing stakeholders, whether it's a small business concern, state societies, the hospitals, the vendors, our vendor representatives, to the table to bring about the best practices and share their perspective and interest to come out with an MSO program is very hard work. And it takes a lot of time, but they've done that, and they've forced, really, quite frankly, the ENAC process in there, which is a very valuable process. And I think while MSOs, certainly we, Zane Networks is an MSO, while we've gone through the process, you're afraid, you want to pass, but you don't know if you're going to get there. But I think that once you're in it and you've gone through that effort, the value that brings to you and the benefits to your market and your members is extremely important. And I would encourage other states to look at that and to bring stakeholders to the table to help come up with an MSO program or an MSO-like program.
Luigi, I think that's a very good perspective, and I think that MHCC, as well as New Jersey, I mean, all the states, I mean, are that have taken and created legislative, really policies having to do with accreditation and moving the needle forward. I think it has been excellent. MHCC has certainly been a model, and they've actually, I think the advisory groups that they have formed, whether or not it's MSO, whether or not it's even now looking at telehealth, telemedicine, and other initiatives that they're focusing on, I applaud them as well for, and again, as they indicated, initially we have ENAC has a very strong partnership with MHCC, and we're very pleased with a lot of the work that we do on an ongoing basis with them. So, we have any more questions, Ron?
No, we don't have any more questions at this point.
All right, great. So I've got a question, Craig, for you. Basically, how is, the ENAC accreditation, how's that changed kind of the MedChi EHR outreach and the support strategy that you have for what you're doing with your organization?
Yeah, I would say it probably changed in two dramatic ways, one internal, one external. So internally, what it does, and we're not a large organization by any means, but I think this probably goes for most places, that there are a lot of priorities and they're all running different directions. And when you as a group commit to doing something that is as strenuous and requires as much focus as ENAC or any other national accreditation, everyone must be on the same team. So I think the first thing it did was really put resources behind our philosophy of supporting health IT. So internally, I think it really helped support what we wanted to do. Externally, in a similar way, I think it helped align kind of the marketing message that was coming from our policymakers, that was coming from other MSOs, and that was coming from the CRISP Regional Extension Center, because everyone was saying you need to adopt health IT, you need to be safe about it, you need to work with good organizations. But prior to the accreditation process and prior to the policy, there was never an answer, well, who is that? And so from an outreach standpoint, it helped us tell our physicians, well, the MSOs are who you should talk to. It gave a very clear answer to some of those more ambiguous questions that actually can be a huge barrier to adoption for a very busy physician.
That's great. Anything, let me just follow it up, Craig, with, as far as how have the physicians as stakeholders that you deal with, again, that MedChi deals with, how they responded to ENAC accreditation as well?
I think that the ENAC accreditation specifically is one of those things that physicians don't know to ask for, and they don't miss it if it's not there.
Right.
But if we can go into a practice and say that we want to help you, we know very specific things you should do in your workflow and to protect you and your patient, and by the way, these are best practices and supported by ENAC, then I think physicians feel very good. It almost feels like the EHR certification before most systems were certified. And a physician didn't know what to ask for, but then once it became popular, built momentum, and they were educated, they knew, okay, no, this is a good thing to look for. So it just became, and I think it's becoming even more so, almost a standard price of admission for working with a practice.
Good, very good. Thank you, Greg. Hey, Bill, one question I had, I was thinking for you, as you have built the New Jersey High Tech and the Regional Extension Center there, and you've had some tremendous success. I know you've got, I think, over, probably well in excess of 6,000 physicians now that have been signed up with you, and you're providing a variety of services to those physician groups in the REC. And you're looking across kind of, I would say, the geography and the map landscape as far as the various stakeholders, not only in New Jersey, but in the industry. How do you see kind of are you seeing the role of MSOs as well as the regional extension centers? How is it playing out? Are you seeing as well, you got the HIEs, the ACOs, how are you seeing some of all these stakeholders, and how are you seeing it kind of playing out over the next year or two here?
Well, Lee, you and I have talked many times about this subject, and my thought is it's simply this, that if you are taking in and distributing electronic health information, clinical health information, in any format, whether it's in claims files or in electronic health records, you've got a massive exposure. So call yourself an MSO, call yourself an EHR, or an HIE or an HIO. It doesn't matter what you call yourself. You have this problem of having a substantial risk of harm to your organization if something goes south. And if it does, the fines and penalties and the sheer embarrassment is going to be critical to your future survival as a functioning industry. So my organization, as a regional extension center, for instance, we're involved in a couple of things. One of which is we are now a CMS qualified data registry and a DSV registry, and we are selling our services to other states, to QIOs, and to other providers that have to submit clinical health information as part of their incentive programs, whether it's HEDIS or CHEPRA or some of the others. My point is we're taking in protected health information. We're aggregating it. We're sending it back out to CMS and back and forth bidirectionally. In that situation, I can't, as an executive director, take a risk that we're going to have a privacy and security violation because I can't be everywhere, every place, all the time. Right. The only way to make sure that we're doing the right thing is to make sure we have an accreditation process. So I think the lines between names and what you call yourself is completely blurred at this point. And if you're doing the duty, if you're doing the job, you have to be careful. So that's my opinion.
Thanks, Phil. Appreciate it.
Yeah.
Phil, this is Sharon. I couldn't agree with you more in terms of the huge risk exposure and how accreditation sort of narrows the things that you have to think about. In other words, it translates, it interprets the sometimes vague and confusing rules and regulations in a way that you can actually execute against and operationalize. And just as a total side note, we've been waiting for, I don't know, guys, how many years for final guidance from HHS on all the privacy and security rules.
We're still waiting.
There's a lottery that you could enter on the internet about the date that actually HHS and OCR will come out with the final rules and regs. And so given the lack of guidance, if you will, or interpretation, accreditation it's a really good thing to rely on because it looks at the industry, looks at the experience of others, and condenses the regulations into like something that you can actually execute against, as opposed to just flat out reading the rules and regs yourself and trying to do the best that you possibly can.
I certainly wouldn't want to take a chance. I kind of look at it like going out in a heavy snowstorm in a blizzard without a coat on. You're taking a hell of a chance.
I wouldn't agree. Couldn't agree more with both of you. Hey, Sharon, one follow-up question, and again, let me ask any of you as participants on the webinar, if you do have any questions, please type them in, and we'll look to get to them. One follow-up question I have for you, Sharon, is as we've been talking about the MSOs, what are the specific compliance obligations of an MSO if an MSO has a third-party subcontractor that they're working with, Sharon?
Great question, Lee. Thank you. We are still awaiting final guidance from HHS on this topic, but the best practice is for MSOs to have a business associate agreement with any third parties in their network with whom they subcontract any of their obligations. So, for example, an EHR conversion might have as a project having a third party take paper and render it into a digital format. The subcontractor agreement that the MSO would have to enable that EHR conversion should also encompass compliance by the subcontractor with HIPAA and high-tech regulations. We call those things sub-business associate agreements or sub-BAAs. It's important that if you're an MSO that you use all reasonable measures to protect any PHI, not only in your own organization, but in the broader network in which you're participating, so that everybody is in the same boat and on the same page with compliance with HIPAA and high-tech. And incidentally, Lee, you mentioned earlier that the government has increased audits and scrutiny, and I just wanted to add on that in the business associate area especially, it's important to pay attention to these compliance obligations, since the Office of Civil Rights has the ability to take the fines and penalties that it has received and self-fund more enforcement under HIPAA high-tech. So, for example, the $4.3 million that Signet paid to OCR and HHS was then added to the OCR budget to do more enforcement and create more audits for covered entities and business associates and subcontractors. So in effect, high-tech has sort of upped the ante and added on an additional layer of government scrutiny. So that's why we're seeing more audits today.
Yeah, very interesting. Very interesting. Sarah, let me ask you one other question, and then we'll see if we have any others to before we close out the webinar. So the one other question that I had for you is basically, as Maryland has been moving forward as far as the model there, what's kind of your vision? What's the vision of MACC on where you see MSOs in Maryland in the next few years, Sarah?
Sure, thanks, Lee. We see MSOs as a critical component to furthering the adoption and use of technology, expanding the models from beyond EHR implementations to how are those EHRs used, how can those EHRs generate data that could maybe impact and help public health programs, how are those EHRs connecting to other sources like health information exchanges, and how are they using telemedicine. How can we combine all the different components with MS together to maximize the efficiencies that are gained through health information technology adoption?
Great. Great. Thank you, Sarah. So let me just ask one more time if we have any other questions out there. And I guess my last question then, while we're waiting and seeing if we have any others out from our participants. Luigi, based upon kind of what you've seen as far as the adoption and growth, and I know primarily your focused areas as an MSO, any other, I would say, parting words that you would give as far as recommendations or advice or guidance to other MSOs that are listening?
I would, thank you, Lee, for the question. I would recommend to MSOs that they really look at where the market is trending and look at the services and the tools that these shared saving programs and networks, emerging networks are going to need, provider networks are going to need, and to begin to figure out the partnerships and relationships that an MSO can develop to help address that marketplace and address it at the price point that the marketplace will find palatable. I think it's extremely exciting. The next few years will be very exciting, and MSOs will be well served in strategizing on how to address that marketplace, continue to grow their membership, and focus on privacy and security.
Great. Thank you, Luigi. Ron, do we have any other questions?
No, there are no more questions, Lee.
Okay. So let me take the opportunity to thank all my panel for really an excellent overview and perspective on MSOs in the industry. We thank Craig Beam, Executive Director of MedChi Network Services, Sharon Klein from Pepper Hamilton, Luigi LeBlanc, Technology Director of Zane Networks, Bill O'Byrne, the Executive Director of NJ High Tech, and Sarah Orth, Chief of Health Information Technology from MHTC. And I want to thank all of you for participating and for your great insight, and thank all of you as participants for listening into our webinar. We plan to have additional webinars, so please look for press releases and other announcements on other webinars that we'll be having in the future. And let me thank Ron Moser for helping to facilitate all the technical aspects for the webinar. And with that, have a great rest of the week, and thanks for your participation. Take care, everybody.